Okay.
Welcome to podcast 13.
I'm Fran.
And I'm Minnie.
And as always, we'd appreciate your feedback. Thank you. So today's topic is nephrotic syndrome in children.
Okay, and our tip for today's podcast is consider dipping urine in children that present to you.
Okay. Yeah, so that's not just for nephrotic syndrome. That's also to rule out urine infections. For example, if you have a child with a fever and you can't find any other cause, then it's important to rule out a UTI as a cause for the infection.
Excellent.
Right. So our discussion, we're going to start with a case study, if that's okay. So I'll run you through that. So Ben is a 5-year-old boy and he comes to your clinic complaining that his clothes are feeling a bit tight. He's tired, he has some tummy ache and some loss of appetite. And his mother says she's noticed that his face looks puffy, especially around the eyes. So on examination, he does have some swelling around the eyes, so that's periorbital swelling. He has some ankle edema and some mild generalized abdominal tenderness, but there isn't any ascites, which is fluid in the abdomen, or organomegaly. So his liver and his spleen, kidneys, etc., all feel normal size. And you check his blood pressure, and it's normal for his age. His pulse is 100, and his perfusion is normal with a capillary refill time of 2 seconds. As per our tip, we ask for a urine sample and we dip that, and that shows 3 pluses of protein and some blood on dip only. Looking at the urine itself, there's no obvious blood there. And the past medical history is that he's had upper respiratory tract infection a few days earlier, but is generally otherwise well and has no family history of note. So in this case, you think this is most likely to be nephrotic syndrome, and that is a specialist illness. He needs to be referred to hospital for further management. This isn't something that we would normally manage in the community. He needs to be under the paediatricians.
Great, thank you, Fran. Yes, it certainly is a condition that you'd refer up, but if it becomes a recurring problem, it may well be something that you would end up managing with the family locally if that suits them. So we'll talk a little bit about nephrotic syndrome. A lot of the treatments are done in hospital, but we thought you might find it quite interesting nonetheless. So nephrotic syndrome is a clinical syndrome, and it's caused by the increased permeability of serum protein through damaged basement membranes in the renal glomeruli. So basically the kidneys become very leaky of protein, and this results in massive proteinuria, and that's calculated at greater than 3.5 grams a day. And this also results in very low albumin in the blood, and on your blood test you would see this being less than 30. So the initial symptoms that are caused by the loss of protein, so this results in the edema, the swelling that you see, problems with the lipid profile, hypercoagulation, a lot of your coagulants are proteins. You get reduced renal function. This is usually secondary to hypovolemia, and again, as antibodies are proteins, you can have problems with immunological disorders and become more prone to infection.
Okay, so the average incidence of nephrotic syndrome is 2 to 16.9 per 100,000 children worldwide, and it varies amongst different ethnic groups, but certainly it is something we have had some questions on the website about, so we thought it might be helpful.
Lovely. So we're specifically talking about children because the management of nephrotic syndrome in adults and also the morphology is different. So typical features in children is that they are generally responsive to steroid treatment, which is good. And this is likely to be something called minimal change nephrotic syndrome, because on the biopsy, you usually don't see very much unless you've got an electron microscope.
And these are the children so these respond to steroid treatment, and so you were saying it's a better indicator, giving them some steroids than looking under a microscope. Is that right?
That's right. Yeah, and
Okay.
also if you respond to steroids, this is good for your long-term outcome of your renal function. So generally, you're going to come off better from this than if you've got a more complicated form. So the typical clinical features of someone presenting to you, very much like Ben, our case really is edema, but this may be quite an insidious onset. So, just having a little bit of swelling around your eyes in the morning might be all that is happening and nobody really notices.
So insidious meaning gradual.
That's it. Yes, exactly. But the edema can occur all over the body, from around the eyes, ankles, lower limbs, tummy. Some people notice that their urine is frothy. People may present to you with symptoms of a DVT due to the hypercoagulable state, or they may present with recurrent infections, general fatigue, lethargy, poor appetite, very similar to that which we've seen in our case here.
Yeah. And so with nephrotic syndrome, you're saying it's large amounts of protein in the urine, and so with a dipstick, that's more than 2 pluses.
That's right. Yeah.
Yeah, and so we wouldn't expect you to measure it in the lab, and you probably can't do a protein to creatinine ratio, but if you could, it would be more than 200 milligrams per millimole. And again, you mentioned them having a low albumin, which again, we're not expecting you to be able to measure.
No. So nephrotic syndrome, we can classify it into 3 main groups. So there's the idiopathic or the primary nephrotic syndrome, and this is primarily a problem with the kidney, and minimal change nephrotic syndrome, which is the one that's most likely to respond to steroids, accounts for about 80 to 90% of the nephrotic syndrome that you see. And then there are a couple of others, focal segmental glomerulosclerosis. So this is little focal areas in the kidney, rather than it being all over the kidney, is 10 to 20%. This has increased over the last 3 decades, actually, as a cause.
Okay.
Then we have secondary nephrotic syndrome, which I think is quite important to think about. So other causes like HSP, which we talked about in our previous skin podcast for the rashes, SLE, and infections such as HIV or hepatitis B or malaria. So it's worth bearing this in mind when someone presents to you with symptoms of nephrotic syndrome.
Yeah, and that may be why we've been seeing it quite a lot coming from you guys in Zambia as a secondary thing to malaria or filariasis as well, although I'm not quite sure how much filariasis you see out in Zambia.
And the final classification is congenital nephrotic syndrome, which has a genetic base.
Okay, and so they may have a family history for that, would they, Minnie?
Possibly, but congenital nephrotic syndrome has quite a poor outcome in that you generally require a transplant by the age of 2 or 3. So it's a pretty poor diagnosis. But there is with some nephrotic syndrome there is certainly a family history element to it.
Okay. So as Minnie said, so there are nephrotic syndrome that's much more likely to respond to steroids, and this tends to present with typical features, and these are that the child is between age 1 and 10 years old, that their blood pressure is normal, their renal function is normal, and that the blood in the urine is only microscopic. So that means it's not able to be seen by the naked eye, it's only when you dip it. And in general, they don't need a renal biopsy. You give them a trial of steroid and see what happens.
That's right.
So in contrast, so atypical features, so these are the children that are likely to need a biopsy. Again, we're not suggesting you do this.
in your rural clinics.
Yeah, so all these children you're referring up. So these are children that are either under 1 year or older than 10 years old. Their blood pressure is raised, so they're hypertensive. When you do their renal function, they have an elevated serum creatinine. They have blood in the urine that is visible to the naked eye, so that's macroscopic hematuria, and they have either systemic or extra-renal disease symptoms, and they have a positive family history of nephrotic syndrome.
So the other thing to note here is that you would want to do the biopsy before you started any treatment.
Yes.
So you get a good picture of what's going on. So that's really why these children, certainly in the UK, would be referred up from the GP straight to the renal nephrologist, the paediatric nephrologist, although there aren't that many of them.
Yeah. So how are we assessing these kids, Minnie?
So you'd assess your child as you would any other patient, but really important is that you assess their volume status, because although they're edematous intravascularly, so within their blood vessels, they are actually hypovolemic. They have less fluid in there than they should, because it's not being held in by the protein that they're weeing out. So to do this, we take a heart rate, we do blood pressure. So a high heart rate would indicate hypovolemia, low blood pressure, which is pretty worrying, or sometimes you see a paradoxical high blood pressure in children. And you look at their perfusion, which we mentioned in the history, Fran. So are they cool around the edges? Are their hands cool? We look for the capillary refill times. This is where you press on a nail bed or on the skin, like on the hand or the feet, and hold it for 5 seconds and then let go and count how many seconds it takes to refill. So it should be less than 2 seconds if it's within normal limits.
Fantastic. Yeah.
We also feel for their liver to see whether that's engorged, and in hospital we'd often do a urinary sodium, which is a clever way of telling you whether someone is hypovolemic even when they're edematous. So this would be very low in their urine. Yeah.
And you said you have some guidelines on this, do you? We could upload those to the forum?
Yeah, so I can upload some of the guidelines of treating hypovolemia in children with nephrotic syndrome, because we used albumin here, which you have to be really, really careful of and monitor people very carefully when you're giving it. So if they're in shock, obviously, then they need resuscitating more quickly than if they're without shock. So the guidelines are quite interesting to look at. I wouldn't be expecting you necessarily to be doing this in your communities.
Yeah. And then just going back to assessing them, so we've done all their heart rate and their blood pressure, but we'd also be doing their height and weight and seeing what that shows. Yeah.
So the weight is quite important as well for continuing management, to see how you're doing in terms of losing that excess fluid.
Yes. So it's a bit like, because we talked about heart failure, didn't we, in another podcast, and we were using weight then again to again with the patients with heart failure, again, quite often the fluid is in the wrong place effectively.
Exactly.
But you're looking at getting their weight down. So we've talked a little about investigation. So we're going to dip their urine, and we're looking for the amount of protein, and we're looking for blood. We're looking to see if there's any infection there. So if you're able to send it off to culture, that would be helpful. You're looking to check for glucose. If you had the ability, you would do what's called a protein to creatinine ratio. And then Minnie talked again about this urine sodium concentration, which gives you more indication of their fluid status. Blood tests. So we talked about how they have this hypercoagulable state. That's really hard to say.
That's
terrible.
That's not just me.
So we'd want to check their full blood count, so looking at their platelets and their clotting screen. Obviously, we'd want to check their kidney function and their creatinine. You'd also want to check their LFTs. And you've mentioned here doing varicella levels. What's that about?
Because the treatment is steroids and or other immunosuppression, you want to know whether or not your patient has had chickenpox, because if they come into contact with it whilst they're on these medications, they need to be treated with an immunoglobulin to protect them from getting a fulminant infection, because they're very susceptible to this on these medications.
Fantastic. And then, so as Minnie was saying, the second group of causes of nephrotic syndrome are other infections. So you'd want to be looking to see if any of those are present. So, if they have a sore throat, do you want to be swabbing that? Do you want to see if they've got malaria? Do you want to do their hepatitis and their HIV status? Would you do, what are these C3, C4? Sorry.
So they're complement. So that's looking at the immune status, really, because they can imply things like SLE, so systemic lupus
Yes. Yes, and certainly I've had a neonate who had lupus that was transmitted from her mother, interestingly. And then going back to just your normal investigations, you probably want to do a chest X-ray and an abdominal ultrasound. So on the chest, you're looking to see if there's a pleural effusion there, and in the abdomen for ascites. So how are we going to manage these kids? This all sounds very complicated. Yeah.
Right. So the mainstay of treatment, as we've mentioned, is corticosteroids, and they have made such a big difference in the outcome for these children. It's a 12-week course initially, starting on a very high dose of prednisolone, and that's continued for 4 weeks. And then it's tapered off over the next 8 weeks, providing that you've responded to this. And we can upload the details of how you calculate the dose, because we do it based on body surface area. And it's got a great equation.
For all of those who are very into mathematics.
Yeah.
So that'll be on the transcript. So click on that link if you're interested in having a look at the dose of that. Right.
Lovely.
And so as well as the steroids, what else would we do?
So we need to think about covering them for infection, as they're very susceptible. And penicillin is usually given orally while there's proteinuria, so whilst you're still producing protein in the urine. These children are at risk of infections such as pneumococcus, and infection is actually one of the main causes of death for children with nephrotic syndrome, so it is important that we treat them.
Right.
The other thing is to consider giving a pneumococcal vaccine for children with nephrotic syndrome if they haven't previously received one.
Fantastic. Yeah.
Other things you need to think about is on steroids, the side effects of steroids. So you need to give them some gastroprotection, so either ranitidine or omeprazole. And the other thing to think about is the diet and fluid management. So I've talked a little bit about treating with albumin for hypovolemia, but without shock, and with severe symptomatic edema. So if the skin is breaking down because the edema is so tense, then sometimes you need to treat with a small amount of albumin and furosemide just to alleviate these symptoms until the nephrotic syndrome is under control.
Okay. And then you're advising these patients to follow a low salt diet to prevent further fluid retention and edema, and sometimes fluid restricting them as well. And again, sort of harking back to the earlier podcast in heart failure as well, we talked about fluid restriction, didn't we?
Yes, all quite similar. But when the child goes into remission, so when they're better, you can lift these restrictions. So it's not something that they're on for life.
And so 80% of children with the first course of steroids will achieve remission. So that means they're symptom free, but then they go on to relapse.
It's a high proportion.
It is, isn't it? And so this carries on until when? How often do they relapse?
So 70% of them will relapse from the first group, and then 60% of these will relapse up to an increasing of 5 times through their lives. But usually once they're over 10, they tend to stop relapsing if they're following that course.
And so a relapse is diagnosed if they've got more than 2 pluses of proteinuria for 3 or more days in a row.
That's right. And the other quite interesting thing is if they respond really quickly to the steroids, so within 7 to 10 days of starting the treatment, then that group tend to have fewer relapses as well. So they're obviously more sensitive to the steroid treatment.
Yeah, and this is something that, like Minnie was saying, so although you wouldn't be doing the initial treatment, if they're relapsing and the parents are engaged, then possibly these are the people who could go home while they're on the steroids, and they could be monitoring the amount of protein in the urine themselves and just coming to the clinic a few times each week just to be checked. Yeah,
it's much better to pick up any relapses just on the urine dipstick rather than waiting for the signs that, the periorbital edema. So obviously things have got a lot worse by that stage. So if you can pick it up while it's
early on,
then you're going to hopefully get in there and treat it more quickly and be better all round, really.
So we talked that only 80% it works for. So there's obviously this percentage of children that the steroids don't work for, and then you're looking at using these immunosuppressants that we use in other illnesses as well. So things like cyclosporin, cyclophosphamide, tacrolimus, things like that. And that is, that's very specialist care, and you need to be very careful with them.
That's right. Levamisole is the one that's used most frequently and often along with the steroids. And just in the last few years, they've started to use a monoclonal antibody, actually.
Gosh, okay.
I'm not sure I can pronounce it properly, but I'll give it a try. Rituximab.
Lovely, well done.
But these are, they're for very difficult cases that are obviously proven very hard to treat. And as you said, they need very careful monitoring.
Yeah.
Okay.
And so Minnie talked a little bit earlier about the complications. So she mentioned that infection was one of the main complications, and this is what the kids die from. But obviously at presentation, when they are hypovolemic, they can go into shock. And we also talked about this hypercoagulable state, which none of us could say very well. And so this just means that your blood clots much more easily, and so you risk getting thrombosis, so these blood clots. And certainly if those can kill, unfortunately. So these are the main complications. Yeah. And so the outlook, Minnie, tell us a bit more about that.
As I alluded to earlier, this has improved hugely with the use of steroids, and it has reduced the mortality rate from about 50% to 3%.
Wow, that's extraordinary, isn't it?
Yeah, it's fantastic, it really is.
Gosh, just from some prednisolone, how fabulous. Yeah.
And relapses occur less frequently as children get older. And if you've had an episode of nephrotic syndrome and you've had no protein in your urine for 5 years, you're very unlikely to relapse.
Okay, yeah. And so in terms of sort of long-term, aside from relapses, long-term kidney damage, what's the chances of that?
So in these children that have the steroid responsive ones, the ones that are likely to have the minimal change disease, they have very little risk of kidney failure further on in their lives, so that's a really good prognosis for them. However, the children who have the other conditions, such as the focal segmental glomerulosclerosis, or FSGS for short, or the membranoproliferative glomerulonephritis, they have a variable outlook, and some of them will go on to develop permanent kidney damage, unfortunately.
Okay.
The secondary nephrotic syndromes that we talked about, so these are the ones that are caused by infection or immunoproblems. These are generally treated by treating the underlying cause for the primary illness. So antibiotics if it's an infection, altering your HIV medication, or treating malaria, or whatever it is, at the same time as using the same treatment plan as you would for the primary nephrotic syndrome. So that's the steroids, essentially. Okay.
So doing those in combination, brilliant. And then the congenital nephrotic syndrome, which we talked about earlier, you mentioned already that most of these kids need a kidney transplant. And, I mean, even in the UK, it's hard enough to get a kidney transplant. I'm sure in Zambia that's not something that people are looking at.
Most of them are on dialysis, awaiting
yes,
in their early part of their lives, unfortunately.
Gosh.
But the overall message is that it's, primary nephrotic syndrome is really treatable, and the children generally do really well now.
Fabulous. Right, well, thank you very much. It's goodbye from me and my slightly barky dog in the background, so apologies for him. And thank you very much for listening.
Okay, thanks very much. Bye.